In this episode, I'd like to talk about sinus floor elevation grafts. We have been doing these grafts for many years since the advent of this concept introduced by Hilt Tatum. Just because we have been successful at this technique for many years, it doesn't mean that we really understand the underlying biology. I'd like to propose an alternative concept to plan and understand what is actually happening. Now, in order to introduce this concept, I will start with a relatively simple case. This is a gentleman who presents with a missing second premolar. This is congenitally missing, so that we see a typical radiographic appearance of a deficient alveolar ridge and the sinus descending into that volume. There is obviously no adequate volume to place a dental implant into this area, so that the common concept is to graft this area to establish a volume of bone and then place a dental implant. Before we begin this case, we need to really understand how the environment into which we plan to do this reconstruction is being maintained. Because unlike a common approach to this problem, and that would be to place a graft and depend on the graft material itself to create a living ossicle, I'm introducing this concept, which is that growth of bone into this volume is not primarily determined by the graft material itself. Rather, the surrounding environment is the determinant of how this will heal. Now, we see here that the walls of this chamber are bounded by the periodontal structures of the adjacent teeth. My proposal is that the walls of this chamber are primarily being maintained by the Sharpy's periodontal system of the teeth adjacent the defect. Therefore, the healing or regeneration of this site is going to depend on the integrity and physiology of these periodontal ligaments, the Sharpy system. In addition to the periodontal system, we also have the sinus membrane itself. Now, the sinus membrane is also a structure that is important in the regeneration. Like the periosteum, we can see that the sinus membrane is anchored to the cortex of the sinus floor with a Sharpy's fiber system. This Sharpy's fiber system is critical in the regeneration of the bone volume, as it is a part of the physiologic system that maintains the defect itself. When the sinus membrane is elevated during sinus lift procedures, the Sharpy's fibers that anchor the Schneiderian membrane to the sinus floor are severed. Part of the severed fibers are maintained in the cortex of the bone, the sinus floor, and part of the sinus fibers are elevated with the sinus membrane itself. In response to the severed fibers, the site will initiate a regenerative process utilizing a system that is the same as the fetus used to create the skeleton to begin with. Now, we place dental implants in this region. This is a single stage technology. So I'm proposing that we place a dental implant into the chamber and then secure it with a small bone plate to create a stabilized environment. The question here is, what material, if any, should we place into the void that we are trying to regenerate a living bone from? Now, conventional thinking is that the generation of bone into this chamber is dependent on the quality and function of the bone graft material itself. Any number of graft materials are used, including no graft material at all, and we have documented successful results in many cases. The question really is what is the purpose of the graft material? What are we asking the graft material to do? So the selection of graft material is important in achieving the objective of creating a living bone volume. So many graft materials are being proposed, but the question really is what are they doing anyway? Now, I'm going to back up on this and say, well, is the graft material the primary focus of the regeneration, or is there another mechanism that has been unrecognized in play here? So I'm going to propose that the Sharpy system that bounds the environment, that bounds the volume of bone that we're trying to create, is the primary process by which bone grows. Now, the Sharpy's fibers that are exposed during the elevation of the sinus membrane respond by a budding process, and they grow into the chamber in the same process that bone forms in a fetus, and also bone forms as a response to injury or surgery. So we see here that the Sharpy's fibers that have been amputated as the sinus membrane was elevated begin to bud towards the chamber. Now, these fibers extend into the void even though there is no bone in that volume. So the fibers extend into the volume first. As in response to the fiber extension, the bone at the wall of the chamber begins to creep forward along the path that has been established by the Sharpy's fiber network. So as the fibers grow towards the middle of the chamber, bone follows behind. So it is important to understand that the Sharpy system is creating a precursor matrix for bone formation. So as the bone follows the fibers continue to descend or follow into the volume of the chamber, and slowly bone forms behind them until the chamber is entirely filled. And in fact, as the fibers approach the titanium cylinder, they surround the cylinder, creating osseointegration. So the volume of the chamber is filled with bone material. Now, that is not the only function or objective of regeneration. Simply filling the chamber with bone does not provide a functional ossicle. So the Sharpy system then directs the immature bone volume into organization into a structural unit. We know from the work of Jean Aaron at the University of Leeds that bone which has been injured by either surgery or trauma is healed by a process of extension of Sharpy's fibers into the volume, into the defect, and then bone follows behind it. So a Sharpy's fiber precursor is necessary to create bone formation in a membranous situation. Now, Jean Aaron is a bone scientist at the University of Leeds in the UK, and her work is critical in understanding how this system actually works. Aaron determined that in the fetus, the membranous bones formed in response to a Sharpy's fiber matrix precursor. This is critical in understanding how membranous bones formed initially in the fetus, and this has been previously really unrecognized. Now, Aaron's team went on to show that this Sharpy's fiber matrix precursor remains active in the adult and is hidden within the mass of collagen fibers that we know to be structural bone. She was able to image the special fibers that were embedded in the structural bone and then are the controlling agents, the controlling pathway that allows bone to form in response to surgery. Now, in a clinical setting, here we see the same patient as before. We have performed a lateral window and sinus lift. We've created an osteotomy for placement of the implant, and there is minimal bone, as you can see, in the sinus floor. Now, the implant is placed and has no primary stability, so it is secured utilizing a small titanium bone plate. Above and around the cylinder, which is in this sinus lift chamber, I have placed a collagen sponge with a small amount of bone morphogenetic protein. So there is no particulate matter in this graft. It is simply a absorbable collagen sponge with bone morphogenetic protein on it. So we use this system, it's a small bone plate to secure the implant. Now, after 4 months, this is what this site looks like. Now you can see that there is a calcified or radiopaque mass that surrounds the cylinder and extends apically into the sinus cavity. It appears after 4 months that some type of calcified material is forming in this region. Now you have to understand that there is no calcified material in the graft itself, so all of the radiopaque material that you can see here has been created in response to the bone morphogenetic protein. Now, we see here that there is a demarcation of the calcified mass with the sinus cavity above. And it's important to understand that volume is being filled with the calcified material in response to the sinus lift and this material. However, we also need to understand that the graft has to both form bone, calcified material, plus it has to remodel and adapt and organize into some type of functional ossicle. Simply filling the volume with a calcified mass that shows on an X-ray is not a real complete reconstruction. Even if the implant appears to be stable, it doesn't mean that this ossicle is fully incorporated physiologically into the system of that site. Now, after 4 months, we uncover the implant, we retrieve the bone plate, and it appears that this implant is stable, so that it goes on to having a dental crown placed and placed into function after 4 months. Here it is. We see that after we remove the bone plate, the cylinder appears to be osseointegrated. Clinically, it is stable, so we empirically place the dental crown on it and place it into function. However, it is not clear how well the bone is actually adapted into this site and how much of it is participating in the structural support of the implant, because the implant could be simply secured by a minimal amount of bone and the ossicle that we see on the X-ray simply superimposed upon it. There isn't really a way to determine the completeness of the integration of the cylinder or how well the ossicle has been incorporated physiologically into this system. Now, this is critical. After 7 years of follow-up, we see this is the result. This is after 7 years of being in function, and we recall the patient to understand what has happened over that time. Now you can see here that the sinus floor itself has descended to the apical region of the implant. There is a clear radiopaque cortical outline, which is the reconstructed sinus floor. which is a natural physiologic and anatomic structure. Important also is that there is a incorporation or organization of this bone mass which demonstrates normal trabecular structures. The anatomy, the architecture of the bone mass is simply not a radiopaque mass that obscures X-ray penetration, but you can see that the structure has also created an architecture of trabecular patterns that is identical to the adjacent bone. This is the implant and crown after 7 years in function. So in review, we place the implant into the chamber. We place a minimal amount of a grafting material, which is intended in this case simply to increase the population of cells. It is not necessarily intended to create structural bone. It is conceivable that there are enough native cells, adjacent cells in this chamber that no graft material is needed at all. So it is possible that we could have just put a collagen sponge or nothing in that chamber and it could have healed anyway. So the objective of this graft was simply to increase the population of cells at the site that would be available for the Sharpy system to work upon it.